Hello and welcome to the Auditing Antics podcast. So, before we start today, Michelle, I just want to give a shout out to our listeners and everyone that's been a part of the podcast so far. I actually met a listener last week, and it was one of those things where we do this podcast every week, and a lot of the times where to not that Michelle enjoys this part, but I'm like, okay, this is what we're going to talk about. Here's some talking points, and we jump into it quick. But in all of the busyness, I forget about how much growth we've had and how many people are joining us each week. And I just got excited this past week because I talked to somebody, and he's really working hard in the industry and wanting to run his own business and learn as much as he can. And he was, telling me how instead of listening to music at the gym, he sits and listens to Michelle and I in his ears. So,
Maybe
that
that should be motivation for us to get to the gym.
yes. Exactly. But it was just kind of just that reminder, that nice reminder that yeah, there are a lot of people here
Mhm.
with us even though we don't see you all on a regular basis. So thank you for joining. Whatever platform you're listening on, if you can go in and rate that, whether you rate the show, the episode, leave comments, share, all of those different things help. And it's nice when we kind of remember to check back in and see where things are at and look at that growth. So,
Yeah, that's cool.
yeah. All right. So, today we're going to be touching on some telehealth. And, this is a really hard conversation still because there's a lot of unknowns. And around that same area, I just want to give a quick update. So, Terry Fletcher and I were going to be doing a telehealth encore today. We thought the government was going to be back open, and they're not. So we decided that we're going to just wait. We're going to postpone it. We don't know the date yet, but we want to wait until the government is no longer shut down so that when we have that event, we can, maximize what we're helping people with. Right now, like we're going to talk about in this episode today, we're in a holding pattern. So, with that encore event, we just want to ensure that we can give everybody advice and help work through whatever this is going to look like after the government shutdown.
Mhm.
Now, where we're at right now is pretty frustrating because we have a couple of different situations. So, Michelle, a lot of clients I've talked with and a lot of members in my Compliance Connection membership have been talking about the fact that they're struggling because now, yes, Medicare is not reimbursing telehealth unless it's behavioral health or mental health or substance use. There's some
Yep.
caveats there, and stage renal disease for the check-in appointments with the patients. So
Mhm.
outside of those few scenarios, we don't have reimbursement, but then we have practices who a lot of times thought, well, the government has always extended. We're just going to get another extension. It's not going to be a big deal. We don't have to change our workflow. We don't have to think about it. And then October 1st hit, and still today, which is October 22nd, we're in this place where we don't have reimbursement occurring and we don't know what that's going to look like going forward.
Yeah, it still is crazy to me that, people literally built business models around COVID flexibilities.
Hmm.
And it's just a little alarming. Um, you know, I I think telehealth is a great tool and it makes healthcare more accessible to a lot of people. But at the end of the day, those were just temporary flexibilities, and there shouldn't have been any assumptions that they would be put into place long term.
Hmm. Well, and the thing that scared me, I've heard now, I want to say this is not my client, but I've heard that there are practices that are just making their own decisions because they don't want to stop the revenue. And it's even so extreme that I heard of one that was wanting to start directing their staff to bill all telehealth a level 3 and bill it as if the patient was in the office. So there's no place of service showing that it's telehealth, and there's no modifier showing that it's telehealth. And
That's bad.
I think for sure we're going to see a lot of this type of behavior happening because people are panicking and they don't know what to do at this point. But again, people also aren't looking at the basics. And, for example, CMS said that you could, they suggested you get an ABN from a patient. But with an ABN, are people actually stopping, talking to the patient before?
Yeah.
Explaining the shutdown, explaining the uncertainty, telling them the cost. Are they trying to change their cost and go rogue off of their fee schedule and say, "Oh, just pay $50, you'll be fine," that type of thing?
And we know historically that ABNs have not been presented appropriately to the clients. So this recommendation is not a recommendation just having blanket ABNs
Mhm.
signed. There is no such thing as a blanket ABN. First of all, let's just say that. Second, just like Stephanie said, you need to be having the conversation with the patients. So, one of the workflow things that you should be doing during this time is giving that front end staff the appropriate training, even giving them scripts if that's what it takes on how to have these conversations with patients and
Mhm.
be ready to step in and help them. Because what's going to end up happening, Stephanie, and we see this all the time, is patients are just going to sign whatever and then they're going to get a bill in the mail down the road. And they're going to be like, I didn't know I was going to be charged for this. I've never had this charge before. And they'll be like, well, you signed an ABN. And they'll be like, what's an ABN? You know what I
Yeah.
mean? I feel like this is just a
Yeah.
classic complaint. So, message to people overseeing staff, change your workflow immediately to train your staff members to appropriately have these ABN conversations. If you are a patient, understand your coverage. Understand how this shutdown affects your coverage. Because at the end of the day, you are the one responsible to know how your services are going to be covered. If you just go in there thinking they're going to, only provide you with what's covered and you'll not have a bill, then you're sorely mistaken, unfortunately. There's so many
Mhm.
different payers out there that there would be no way for them
Right.
to just know across the board, this is the insurance you have, this is the instruction we need to give you. So if you're somebody who has a lot of telehealth appointments and things that fall within this area of unknown, you need to figure out for yourself how you want to proceed with your care in those areas. But at the least in your practice, you need to train your staff to have the appropriate ABN conversation before the patient has the service performed.
Well, and another thing that we should highlight here is just obtaining the ABN, even if you do it appropriately, is still not going to be a guarantee of payment.
Mhm, correct.
So you can go through and follow that, but there's been no guarantee in language that, for example, you'll bill that claim with the proper modifier and then CMS will put it to patient responsibility. We don't have any kind of insight or guarantee on that at this point. So we've got to be careful. And, sometimes practices want to leave this type of conversation up to the physician or the other practitioners. And you've got to recognize as well, especially if you're a larger organization, that just realistically is not going to happen. It's not their focus. It shouldn't
It's
be
not
left
their
to them.
role. Their role
Right.
isn't finances and such. And I think that's a big point of frustration actually for providers currently is it's becoming more and more about the billing and things like that than it is just providing patient care. And everybody wants to pass that conversation off, just
Hmm.
like asking for payment of a bill that's due. Everybody wants to pass that conversation off, but it's most effective when you do it first thing with people who are appropriately trained to have these conversations. Don't pass the buck. I mean, we all
Mhm.
have to have those difficult conversations at times and have to deal with people who aren't happy about what you're saying. So
Right.
if you take the time to train your staff and then also train yourself to be there to support your staff as well as your patient, then it should be all okay. But everybody has a role to play.
Yeah.
And
Well, the other thing that, is concerning right now is how practices also aren't realizing what is left over. And what I mean by that is what is reimbursable. So I talked a little bit about the behavioral health, the mental health, substance use disorder, end stage renal disease. But remember, the other part of that is we no longer have audio only. So
mhm,
even if you're continuing, even if you get this AVN signed, if you are not, connecting with patients through video, we no longer have audio only available. That flexibility went away as well. So there's that issue. And then when we think about, some people are still trying to figure out, okay, well, how could we still do this with the patient in their home? And outside of those covered diagnoses or scenarios, we end up in that situation where you essentially have to be in that HIPSA location, which means that you're in essentially a rural area and you qualify. There's a government website you can go in, put your address in, see if you're a part of that location. Terry and I will dive more into that in our event that we're going to do. But there are ways to tell if you're in this place, but even then the patient has to come into the facility. It
mhm,
doesn't mean the patient gets to stay home because you're in a rural area with a shortage of providers. And when this first happened, I was talking with a client or a member, and they have a client who was making the decision to drive hours to go see patients because there was going to be this huge disconnect in care. And, I think another thing that people forget is we didn't have this prior to COVID.
mhm,
So, some of what needs to be looked at, yes, we've evolved our workflow based on waivers, but what did this look like before? How did you get
mhm,
to the point where this started to be allowed? And, in that situation, it is more extreme because there is no services out there. The patients are just so rural. There's not even a clinic they could go into and then do telehealth from there. None of that comes into play because of how far out they are. But that would be a question that I think of right now too. How'd you get to this point? Is it still necessary? We've talked a lot about, even on the Compliance Guy podcast when I do the roundtable on Mondays. In there, we've talked quite a bit about the fact that, it's only supposed to be if it's necessary still. It's not supposed to be out of convenience.
mhm,
And there are a lot of people that have made these decisions out of convenience. And, I've talked to practices, for example, where a physician no longer even wants to go into the building. They have the ability. Some of them want the patient to go to the building and then they'll stay home and they'll do telehealth from home. And it's like, how did we get to this point? What
I
happened
know. It's
where all
because
of these changes were made?
I think everybody just kinda shifted their thought process to these COVID flexibilities. And something I find actually funny is I still see telehealth statements in my auditing saying that telehealth is being done due to the COVID pandemic and to limit exposure. It's like, no,
Yeah.
maybe you need to that's a a smart text at its finest. Just
Mhm.
blowing it in, let's not even look at it.
Yeah.
But it's I think everybody just got in the mindset that this was life now and how it will be going forward. And we see in other industries too. Other industries have started bringing workers back to the office. They may have some type of hybrid remote, but I mean, honestly, I don't think healthcare was ever meant to be fully remote with doctors just sitting at their homes
Mhm.
providing care. I don't know that that ever was like the true intent.
Well, and some
It's
of the
just evolved
issues.
to that.
Yeah. Yeah, and in this same vein, some of the issues when you were saying, Michelle, that businesses were started based on waivers, there are different practices that I've talked to that don't even have a physical location.
Mhm.
And, depending on the payer and especially the government payers, you have to have a physical location. You can't only offer telehealth services. You have to have a physical location because in some of the different contracts that you're entering into, it basically is stating that the patients have the right to choose. They have the right to choose if they want to accept telehealth or be seen in person. And if you're starting this out as, this practice that accepts those payers, you have to have a physical location.
Mhm.
And, some of what is still up in the air right now for behavioral health, mental health, and substance use is the whole scenario of the patient needing to be seen initially prior to receiving telehealth services within the last 6 months. And then going forward, they have to be able to be seen in person at least once a year, unless that it's decided on that, it's going to be, I forget the exact wording that CMS uses. I want to say something like harmful or
Yeah.
detrimental, but CMS is basically saying if the practitioner and the patient determine that, it's too difficult or whatever the term is, then they can waive the annual visit. But how many people are going to implement that and say, well, we could use this excuse because, of course, it's left wide open. We don't have a lot
Yeah.
of examples. So, how many
It's
people are going to just blow a statement in and say they're never going to
yeah.
see them in a year?
Yeah, and it's one of those things where we're gonna start seeing it's kinda like the G2211 phrase that we see that they think covers their billing of that. It's just gonna be this where it's gonna be harmful for everybody to
Yeah,
come to the office.
yeah,
That's not really, I think what CMS by using that type of terminology is saying this better be the exception, not the rule,
hmm,
because how would it be harmful?
right,
E
right.
e Explain to me a scenario, unless the person's, severely disabled and has very limited mobility and things like that, like, maybe I
Well,
just
and
don't
the
understand.
the issue is that most of these types of organizations don't have enough physical locations.
Yeah,
So what they're looking at now is, they've scaled and they've grown during the PHE and the flexibilities. And now they're looking at the fact that they are going to have to, look at bringing in other leases or purchasing other buildings. And then on top of it, going back to the provider scenario, there's a lot of practitioners that now at this point have gotten used to telehealth and they don't want to go into a practice. And
yeah,
I've seen this more definitely in the behavioral health space, but it's a real concern right now for people who are trying to hire, especially if we're thinking about rural areas and things like that.
mhm.
It just really, really complicates not only the billing, but the access to care, depending on, how this particular part is going to play out.
Yeah, and I mean, I get it. I love working from home. I would probably find something else if I was told you have to come work in the office. No, thank you. I don't
Mhm,
miss that dynamic. I don't miss the commute. I don't miss
mhm.
any of it. I like working from home. So I can understand that. But I think providers also have to understand the purpose of their role. And that's to provide patient care. It's not traditionally a career that is thought to be remote work. You know what I
Mhm.
mean? Like
Yeah, yeah.
it's just kind of the reality of the career you've chosen, just like other people who don't want to go back to the office, but because of their career and what they do, they have to be present in the office or their employer requires it. You know what I
Mhm.
mean? So it's just kind of one of those things where nobody should be surprised that
Right.
these are requirements. And yeah.
Yeah. Well, and the other thing that I've seen too is depending on specialty, I've gotten some interesting questions. For example, with surgical specialists asking if they have to have the patient travel all the way back in for a post-op visit because they don't technically bill them. And, when you think about it and the patient having surgery, like an organ removed or something, how do you know for sure through a video if that patient is okay? The intent
But
of surgical follow-up is there.
they already got
And
paid for it when they got paid for the
exactly.
surgery.
That's
Like that.
another part. Yes, I brought that up as well. It's a part of what they've been paid for. And
Yeah.
not only that, if you look historically, a lot of this we've got to look beyond and dig real deep to understand what our viewpoint is, right? But if you look
Mhm.
at what CMS has been doing from like a data perspective and a research perspective, they have looked for years at that post-operative period to see if it's
Mhm.
even worth bundling it in. And some
Yeah.
of the reason for that is because they question whether or not the surgeons are seeing the patients after.
Yeah.
So, that's why in some states there's the requirement to bill out the 99024 with like a penny. So it'll show up in the claims data as opposed to only in your PM system. It's
Uh-huh.
because they're looking and they're wanting to evaluate whether or not it's medically necessary for that patient to follow up. So if you then say, well, I don't need to see him in person, I can just talk to him on the phone, not even use video, or, talk to him on video, but not examine the surgical site or something like that.
Yeah.
How, in the bigger scheme of things, are you going to justify that part of your global package instead of, getting a small portion for surgery and everything else being broken apart?
Mhm. I
Which I
think
don't
that
think we're there yet, but
no,
that
no,
research has been happening for years.
it has, and I think that for years I don't know what I was gonna say. I
For
forgot.
years
Well, for years
they're
what?
finding that it is deficient, that they're not
Yeah.
always following up.
Yes,
And
exactly. And how many times do you see those follow-up visits where it's just very brief and it's like
mhm,
what was the point of
yeah.
this? Like obviously not every surgery is as extensive as others, and I do
Mhm,
think that that is accounted for in those numbers, but sometimes you have to question why was it even, you didn't even make it seem medically necessary to see this patient even though it's not billable. I
yeah.
think of a situation too of somebody that we know where they had a surgery and had I really think going into the office showed their shortness of breath, their overall, decline and weakness that if the patient had just been sitting at home on their couch or in their bed, they wouldn't have seen the difficulty it took them to come into the office to kind of
Mhm,
start asking those other questions because patients aren't always forthcoming with those
right.
details. And there's a lot more that can be seen than just looking at the surgical site by having a patient walk into the office.
Mhm. And that particular situation ended up in another procedure and a
Yeah,
hospitalization. So yeah,
yeah.
for sure. Well, and a lot of times too, when I'm getting asked questions right now, I'll ask back, what would you have done prior to COVID? Meaning, you're telling me that your practitioner wants to bill this as telehealth, but if we look at the workflow prior, it wasn't anything big enough that you would have had them come back into the office. Because we
Mhm.
still have situations, for example, of providers calling to talk about test results and going through the diagnostics and saying, hey, this is what it all shows, talking about potential in the future, but it not requiring treatment now. And something like that, if it was a scenario before, when a nurse typically would have called to have that discussion, it doesn't mean it's billable just because the physician or the other practitioner called the patient. That didn't
Mhm.
all of a sudden make it billable. So again, we need to look at those types of workflows because a lot of people try to adjust and do these things to get revenue in during, especially when practices really weren't open, and they should have never done it to begin with. And unfortunately, in this industry, what we see is once something has changed and started, we don't see a lot of people questioning it or reverting back to what it was before.
Yeah. And I think it is because so many people had revenue opportunities, I'm going to use
Mhm.
that, where suddenly certain things appeared to be billable when really should we have been billing it. Like you said, that's a really good thought process to have. What did we do before the flexibilities? What was the workflow? And if your answer is we didn't bill for that, there's a reason you didn't bill for that.
Yeah,
Now, just because a telephone call is billable doesn't mean all of a sudden the provider needs to be doing all of these phone calls just to bill people for them because you can now,
right.
or that the codes are allowed. But it looks like we only have a couple of minutes left. So, Stephanie, is there anything specific to office workflow that you would recommend be taking place as we wait for these decisions to be made?
So I think a big red flag in a practice right now is if you've changed nothing. If
Hmm.
your
I
workflow
agree.
has stayed the same. Now, yes, this is largely for Medicare patients, but we have to remember that a lot of times the policies of the Advantage plans are going to revert back to Medicare.
Hmm.
So, yes, we're strongly looking at traditional Medicare right now. I have concerns about Advantage plans. But if you've changed nothing, then there's a problem. And, if you don't have the conversations administratively, meaning that there's a practice manager or someone in, a lead position who's stepping in and working alongside with people who are making appointments. A lot of times practices have automated appointment reminders now.
Hmm.
What does that look like for you? How are you reaching out to patients, making sure that you are educating them appropriately, trying to get an ABN? It's one of those things where you can choose to continue and have the possibility of completely missing out of the revenue. You could have a large compliance issue if you're choosing to hide what you're doing, like that one
Hmm.
group that I heard of through the grapevine. Um, and then, there's the possibility that you're going to implement this new um, substitute workflow and then potentially be paid, but we don't know. So,
Hmm.
either way, there's risks with what's taking place. So, if you are continuing telehealth, you've got to be aware of those risks, have the conversations with administration if you're in a large facility or organization. If you're in a smaller group, you need to sit down typically with that physician owner and talk about what this means and talk about what you want to do. We
Hmm.
really are strongly suggesting not providing telehealth services for traditional Medicare if you fall outside of those covered scenarios, but we know a lot of people are continuing to do that. And you also, clinically and legally have to make sure you're careful to not abandon your patients and look at
Correct.
what that looks like. And I don't have legal advice there. I just know it's a thing. We got to be careful, right? It needs to
Yeah.
be a conversation.
Yeah, I would also add to that that you should be tracking those claims. So if obviously you're still going to be submitting claims, but you should be tracking those ones that fall into those categories where it's unknown right now. The last thing you want to do is not monitor these and then either miss out on the payment because you weren't tracking it, or end up with a compliance issue on the other hand. So either way, I think that the work that goes into it is worth it. Um, we just don't know what the outcome of that work is going to be. So definitely be monitoring those claims, um, your denials, things like that, so that you have a good handle on what the actual scope is that you're looking at when these decisions come through, and when we have answers to the questions that we have.
Mhm. Yep. So hopefully very soon we will have, the government reopening. We will have more permanent answers. We may have, I don't know. I don't know if they're going to do more flexibilities. We have even more that are getting set to expire. So, we don't know what this is going to look like, but hopefully we'll have some answers soon. And as a last quick reminder, you can go to stephanieallardconsulting.com. On there, if you go to the healthcare code compass link, there is a spot to sign up and register for the telehealth encore event. And like I said in the beginning, Terry and I just have it in that pause right now where we're waiting till the government reopens, and then we'll announce the official date. But we do still have registration open for that. So you can sign up. We'll make sure everybody who is signed up gets, all of the details sent to your inbox where you register. And, we hope you'll join us. We hope we can help people navigate this because it's been very messy. So
Mhm.
until next time, thank you for joining us. And remember to go like, subscribe, follow, share, rate all of the things on the podcast so we can continue growing. Thanks.
Thanks.